And it is now my very big pleasure to introduce Dr. Julie Akers. She is a clinical associate professor at the Washington State University College of Pharmacy and Pharmaceutical Sciences in Spokane, Washington. She received her Doctor of Pharmacy from Washington State University in 2000, after which she worked for 13 years in an ambulatory setting as a pharmacist, pharmacy manager, district manager, and director of pharmacy. In 2006, Dr. Akers was accepted into the Wharton GSK Pharmacy Leadership Program. She became a board-certified ambulatory care pharmacist in 2014. Dr. Akers currently serves on the Washington State Pharmacy Association Board of Directors. She's one of my bosses. And past president of the Policy Review Committee. She's also past president of WSBA. She is on the Government Affairs Committee for APHA and is on the 2020-2021 APHA Policy Review Committee. She has served as Washington State's APHA delegate for several years and is on several regional and state health care committees. Dr. Akers is faculty advisor for several student organizations and currently teaches healthcare systems, pharmacy management, pharmacy law, and politics elective. Her research focuses on increasing patient access to quality care through advancing community pharmacy practice. Welcome, Dr. Akers.
Thank you. And I just learned that instead of having WSBA pull like old ones, I'll send you a new, very shortened bio.
I was thinking your title
So
was
we've
not
used up all the
correct
time, and
anymore.
I'll give
Sorry.
you the code for today. I'm sorry. That's a lot of stuff to have to read. I do stuff. I've done stuff and I'm doing different stuff now. There we go. So I also realized that I love this topic because I'm a legislative regulatory nerd, and I realize it's probably the least favorite topic of most people in the room. And add on to that it's post lunch. So I'm just hopeful that at the end of the hour, there's some eyeballs still open, both in here and on Zoom. So I'm going to spend some time. A lot happens every year in DC and Olympia. And so I'm going to be going through quite a bit of that. So federal and state, both legislation and some regulatory affairs administration work, just so you're kind of up to date on what has happened, what we would have liked to have happened that didn't happen, and a little bit in between. Now let's see if the clicker works. Oh, I think the thumb drive isn't in, or it's not on. Stand here. All right, it works now. I have nothing to disclose, at least related to this topic. I am not opposed to having a conflict of interest. If anybody would ever like to give me money related to any of these things, I'd be happy to add something to that slide. Objectives we already kind of talked about for all attendees, pharmacists, technicians, anyone, again, looking at that federal and state legislation and regulations. So starting with some topics that we looked at last year, but still relevant. So we kind of thought this might have gone away by now, but surprise, COVID-19 is still here, right? So PrEP Act, just kind of a little bit of a review. The PrEP Act, they have extended when it will end, or at least the latest as of right now it will end, to October 1st of 2025. So October 1st, 2025, they can end it sooner than that. But I think they also thought like, oh, we'll just do this for a year and see what happens, and realized they kept having to extend it. So they did a multi-year extension. October 1st, 2025 is now the end date, but they do have authority to end it early if they need to. And I can't imagine you all having survived the last 2 years and not known about the PrEP Act. Happy to go into more details later if you want. But again, the big picture is that allows for immunity of providers when we're doing work, especially with drugs that are not FDA approved or devices that are not FDA approved. And there's some protections there. And then the CARES Act, I always kind of say this one has more to do with the money. There's a little bit more to it than that. But again, some of that has already ended. So December of 2021, that financial need due to the impacts of COVID-19 has ended. But the student loan repayment kind of interest freeze was extended through May 1st of this year. Possibly there's some discussion that it could be extended again. We'll see what happens. But that has been extended. So I know there's a couple students or recent graduates in the room who are probably happy about this, especially the interest freeze for now. So really just kind of a reminder that the PrEP Act is still in play, and CARES Act, most of it is ended except for that student loan piece. Do want to just add, because I'm not going to cover it in the state piece, questions come up a lot right now with the statewide mandates and the proclamations. And, you know, I know a lot of people, even this morning, came in and like, some want to wear their mask, some had their mask on because they came in through the hospital and were like, everybody's wearing one, what do I need to do? And so just remembering that in our state, there is still a mandate that healthcare settings have those masks. And so there's been a lot of questions about where does that apply? It makes kind of sense. You walk into a hospital, you go to your provider's office. Not a lot of questions there, but there was questions of, well, if I use Walmart pharmacy and I walk into Walmart, does that mean I have to have my mask on because there's a pharmacy there? Or if I walk into an independent pharmacy, what does that mean for that practice setting? And so can't say that it's a very clear picture. There's still a little fog in there, but the clearest way that I've seen it explained is a shopkeeper's license is not a healthcare entity, right? It is, there could be a 7-Eleven that has a shopkeeper license so they can sell Tylenol. And so that is not considered a healthcare facility. So when you go into those locations that have a shopkeeper license out front, and then they have a pharmacy, the people in the pharmacy are required to have their mask on, but as a patient, because you don't ever enter the facility, the pharmacy facility, you don't go behind that counter as a patient, you don't technically have to have your mask on because you're still in the space of the shopkeeper license where they do. This gets a little harder if you're an independent owner or you work at an independent pharmacy where you have one pharmacy license for the whole space, because then that space is licensed as a healthcare site. And so from what I've been told, then that would apply where patients would have to have a mask on when they enter because they're entering a licensed space for the pharmacy. Again, I always tell this to the students as well. Know the laws, know the rules. Sometimes they're broken, just know you're breaking them. So not gonna go into like what you're actually doing at your locations, but that question has come up quite a bit with this mask thing. I can tell you that many of the independent owners I've talked to have started getting a shopkeeper's license recently anyway for their front end, so they can use a different license to order CBD products and not have it be on their pharmacy license. And so they kind of don't fall into this. They have that shopkeeper license. Many though still just have that one license. All right. Also, just a little bit of recap. Again, so we had this American Rescue Plan Act that was passed last year. It was signed, I think, just about the time we were having new drugs, new laws last year. And so really of this almost $2 trillion, some of this is funneling to those states. And there's a lot here that this money is supposed to be used for, but a couple things that I mainly want to point out. So the broadband, really thinking about access to telehealth, where you're going to hear telehealth, telemedicine, telepharmacy, everything a lot today, at least through this next hour. But really understanding through the pandemic that people had limited access to telehealth because of broadband issues. And so that could end up creating an expanded patient base for some of you and being able to provide telehealth services. The other thing that I wanted to point out was the second to last, the premium pay to workers. So some of this money is to go to premium pay for people who are considered essential workers. Employers can put in for that. There's a max of, they can't increase someone's pay or the premium pay itself outside of the regular salary, can't be more than $13 an hour or $25,000 a year. But that is something, as this money is coming into the state, that employers could be working with the state to try to get some of that money to use for that purpose. Maybe some of you will get a little hazard bonus depending on where you work. All right, and so telehealth, just wanted to bring this up. So this actually was just introduced in February of this year. And really, they're just wanting to extend some of these things that are set to expire with the PrEP Act and put this into a permanent statute. And so they're looking at least first now extending the telehealth rules around COVID, the temporary rules for a couple years to buy them some time to get through this process. And really important that they're looking at waiving this limitation on Medicare, because Medicare would only pay if the patient was at a facility. And so that's part of this and part of the temporary restrictions that were lifted, but they're wanting to make that permanent so we can provide more care and actually bill for that care while the patient's in home. We'll talk a little bit later at the state level where they're trying to address some of the payment issues with that as well. And then the controlled substance piece of this, 2008, some of you might remember we had that Ryan Haidt Act that went through where it tried to restrict, or it did restrict, controlled substance prescribing online and mandated that the patient have had at least one kind of inpatient or in-person established care visit. So we didn't just have controlled substances being prescribed online and there not be a true provider-patient relationship. And so we kind of had some issues with that, right? When COVID hit, and what if they are establishing care for the first time with a provider during the pandemic, and that being online and they are in need of a controlled substance. And so this is actually looking to allow that if that telehealth appointment had audio visual. So it can't just be a phone call. It would have to be like Zoom or Teams or some way where they can actually see one another using telehealth. And then it would override the Ryan Haidt Act. They're also looking at, so for the federally qualified health centers and the rural health clinics, so kind of extending again that ability that they've been allowed to do, at least now with the temporary action, where the provider again can be on site, but that patient can be elsewhere, so they can be at home. So again, some of those things, and trying to really push that in rural settings. And then those critical access hospitals, allowing them the ability to go outside of the hospital facility and provide care, especially to some of those homebound patients or others in those rural settings where that critical access hospital previously didn't have authority to go outside of the facility and provide care. So this is one of those, again, that it was just introduced, they're in discussion, and that's kind of why they did that 2-year extension of the temporary act that was put in place to buy some time while they try to go through this process and hopefully get something more permanent in place. And then I think this is my last COVID related slide. OSHA. So of course we know OSHA wants to make sure that our workplaces are all safe. And they started this process last year. So last June, they put an interim rule in place just, related to workplace safety. A lot of, COVID precautions, PPE requirements were in that. And they started the official rulemaking process. So the full process. They had 2 months, just about 2 months of stakeholdering, and then they sat down to start writing a rule. Well, you can see then they got just to like less than 2 weeks ago and realized we need more stakeholder input to really write this rule well. And so they've reopened it for a limited amount of time for public, more public input on this. So this is open right now. If this is something that interests you, you can see you have until April 22nd. Hopefully in the slides, the link works. That'll actually take you to OSHA's page where you can give comment on this rulemaking. And then you'll want that docket number. They want to know, that's how they track like which topic are you commenting on. So that link is there for you in that docket number if you want to provide comment as they're looking at some permanent rules around this. I am really hopeful that for those of you that have been coming here for a while, I'm really hopeful this is the last year I even have this slide in here. Track and trace, right? I know, don't hold my breath. It's kind of like thinking last year I wouldn't have COVID slides, right? We're almost to the end of this multi-year, right? This act went in place in 2013. We've talked a lot about phase 1 in previous years. We've talked a lot about phase 2. Basically, every product in your pharmacy by now should have the 2D, QR code looking scan printed on the bottle. If you still have product on your shelves with a UPC or the 1D barcode scan in your pharmacy, let's talk later because you might have an issue with your inventory turns. Because we should not have been getting any product from wholesalers without that 2D barcode since November of 2020. So if you have some sitting on your shelves in your pharmacy still, let's talk about your inventory turns. So what's left? We've got phase 3. They are still working on phase 3. And really phase 3 is that multi-level tracking. They're wanting to be able to know from the manufacturer until it gets to the pharmacy at any point in time, because of all the information in that 2D barcode or 2D QR code, it's scanned at each step and they can trace it, right? The other piece that they're building right now is the serialization. And so not only is it every little bottle is going to have that you scan, but each larger grouping of packages as you move up. So if the manufacturer is shipping it to a wholesaler on a pallet, that pallet would have its own individual scan code that has the information for every single bottle that's on that pallet. You open the pallet and then you have maybe groupings that are shrink wrapped together. Each of those will have its own barcode that says, here's actually what's in this shrink wrapped grouping, down until you get to the actual individual bottle. So that's what they're talking about, that serialization is that, when you have a lot of a product, if it's grouped in that way and marked, you're not having to scan all, 100,000 bottles. You just scan that one on the outside of that packaging. And so they're still kind of working on that, and they're trying to still finalize what the system is going to look like that we could get into and see that pedigree of the product as it moves through, that every single person in our closed drug system is supposed to be able to have access to. That's probably why Jenny said, don't hold your breath. But again, it's supposed to be, well, this is true because it's next year. By November of next year, they're supposed to have figured this all out. I've also learned that because this is the federal government working on it, we'll see if it's done by November of 2023 or if it works. I still remember January 1st, 2006 as like my world's D-Day, because it was Medicare D-Day, right? When the federal government sets up a new computer system, it goes great every time the first day they turn it on, right? Okay. So now let's get to the meat of the presentation. So some federal legislation that I say is in the works. So we've had a few things that were dropped recently, and some of these were dropped last year. So this is legislation. What's that? Introduced. Yes, I'm using my lingo. It's been dropped in the hopper, which means it's been introduced, but it's sitting either in the House or the Senate, depending on where it's at in the process. So Pharmacy and Medically Underserved Areas Enhancement Act. This is kind of our federal provider status bill that has over the years whittled down to, it's not going to be everywhere, but now these bills are asking for it in areas that are deemed medically underserved or meet a certain level of criteria. There's companion bills. We have one sitting in the House, one sitting in the Senate, and they've been sitting for just about a year. And from what we have been told, they're likely gonna just keep sitting. Don't know that it's going to move anywhere. There was some hope that as much as we don't want to benefit from a pandemic, that all the work that pharmacists did and pharmacy technicians did and kind of that very visible response, and I don't know, I think our profession helped kind of like save the world. We thought maybe they would say like, maybe we should be federal providers. I don't think it's going to go anywhere, but it's still sitting there. They haven't been voted down. They just are sitting there, not going anywhere yet. However, the second one could actually, there's some traction on the DIR reform bills right now. This one, all hope has not been lost yet. I'm channeling my Star Wars quotes, but we still have some hope with this one. And really because it's looking at lowering Medicare patients out-of-pocket costs is how this bill is written. And so it's really, you know, if it's just stop taking money away from pharmacies illegally, in Julie's opinion, or without clarity and without transparency, it's really worded in a way of how it's impacting Medicare patients out-of-pocket costs. And just because it DIR fees have been shown now to increase healthcare costs overall. And so because there's that angle, there's actually a little bit more support behind it in DC. And so again, we'll wait. It has a companion bill. They've also been sitting for a while. They've kind of been working on some other things in DC the past year, but there actually is some conversations happening around this one right now. So we're hopeful that this one might actually move through and at least provide some clarity and relief at the federal level. We'll talk about DIRs a little bit when I get to the state. And I think the session after me is likely going to talk about some of this, at least reimbursement issues. So I won't go into too much detail on that. Some more federal legislation. I kind of grouped these into topics. So we have a couple bills that are kind of workforce bills. This first one, Building a Sustainable Workforce for Healthy Communities Act, or so this one is really looking at the Public Health Service Act. These next two actually are both focused kind of on Public Health Service Act. So this first one, Senate Bill 3479, is really looking at support for community health workers and people in community health. And so pushing the Secretary of Health to have grants and contracts or agreements with community health facilities and to help them expand their workforce, and really also just to promote those healthy behaviors and outcomes for medically underserved populations. Senate Bill 3506, this one is more focused on that workforce shortage, especially in rural communities. And so many of you are aware the Public Health Service Act allows for up to $35,000 a year to be kind of written off on healthcare provider student loans if they go work in qualifying facilities. But that was also limited to certain provider types, and typically pharmacists were not included in that. Kind of depends on the facility. Most of the time pharmacists aren't included in that. And again, it's up to $35,000 a year, which could, for each year that you commit to working in a qualifying facility. So 3506 is actually looking at expanding that to $50,000 a year. And also language expanding who the qualifying providers are. So this could also open up some more opportunities for pharmacists to be qualifying providers, especially as they move into more AmCare services out in rural health clinics. So excited to kind of see where that one goes. That was just introduced in DC this January. So it's a fairly new bill. We have a rural health bill. So this was also introduced. They had a busy January. A lot of these were all introduced in January of this year. And really, this is a bill where they want to make permanent, again, some of those Medicare telehealth service enhancements 4 federally qualified health centers in rural health clinics. So really focusing on that telehealth access to care in rural communities and trying to make some of those temporary operations that they've allowed from Medicare. So again, like the patient being able to receive care in their home, the providers being able to provide that care outside of the facility, say they're working from home. So trying to make some of this permanent. And then we have some companion bills here and a couple other bills related to supply chain. So we have Senate 3444 and House 6372. So it's the same bill, just introduced in both houses. Also introduced this January. These are really focused on tribal medical supplies. Because of the pandemic, they recognized that our national stockpiles, a lot of our tribal communities couldn't access the national stockpile. And so they're looking at modifying some of that to have equitable access to some of those stockpiles. 6360 also was introduced in January. So this is looking at, I always find this name funny, a supply chain czar. So they want to establish a czar in the executive office of the president to basically kind of look at supply chain policy, especially after the pandemic and some of the issues that we saw with supply chain of everything, honestly. But really when it came down to access to medications and supplies for medications, and I often hear from people in health systems that still struggle with finding saline bags or piggybacks, and there's all kinds of things that they can't get access to. And so they're going to be trying to look at that and then serve as a resource for states as they're starting to employ some of these different acts. And then that last one, 3493, a Drug Shortages Shelf Life Extension Act. This is kind of when we started realizing through the shortages that some of the expiration dates we could extend, right? Because we had supply issues. So they're just going to spend some time digging into that a little bit more. So again, those are all just kind of in the works. We're going to monitor those and see if it looks like they have some support in Congress and if those keep moving through. A couple others, we have some bills that would impact the Food, Drug, Cosmetic Act, also introduced in January of this year. So this first one, improved transparency for foreign drug manufacturing, really is looking to amend that Food, Drug, Cosmetic Act, looking at the requirements that are there for establishing foreign countries engaging in that manufacturing of product that then is shipped into the United States for our US FDA approved pharmaceuticals. So they're just going to kind of look into that a little bit more. The House 6512 also introduced in January. As I said, a lot of bills got introduced in January of this year. So this is the Prescription Freedom Act. So it says that it would repeal the authority of the FDA to require that drugs be dispensed only upon a prescription. But they're looking at specific things. So trying to look at, are there certain things that they could move to over the counter? We're kind of waiting to get more information on that one. And so if any of you are both, I think I've seen notices from APHA, NCPA, and ASHP on this one. So if you're involved in any of those organizations and you get their like legislative and regulatory affairs updates, they're all kind of monitoring this to see what they're looking at and where that's going to go. And then the last one in that grouping, so 6519 in the House, patient medication information required to be on labeling. So we've got labeling legislation being looked at the federal level because of all of the rules around what has to be on labels for outpatient, long-term care, hospital. And we'll talk a little bit later about some things that are happening in our state related to labeling. And then there's some public health bills. Won't spend a lot of time on this, but the Support Act 3476 in the Senate really focused on mental health and substance use disorder services in response to, we had a problem before the pandemic, but it definitely worsened. And so that bill is really to try to look at how can we support making sure we have providers enough providers, and also looking at what the expansion potentially of who is qualified as a provider from a medical billing standpoint to provide those types of services. And then 3489, this one is really trying to just focus. We, again, through the pandemic, realized that we need a lot more research on certain virus families. And so it's focusing on trying to get some funding and to support research related to certain virus families, and trying to kind of get ahead of the game and be more prepared. I'll say if, not when. So if another pandemic should happen at some point, hopefully we're starting out from a better place. We have a couple other, the 6463 is known as the MEDS Act. So it's looking at equal protection of the law, prohibiting discrimination and preferential treatment, race, color, national origin, as it relates to Department of Health and Human Services services. So they're kind of looking into if there are some disparities within that. And so that's what that bill is about. And then Senate 3553 is really looking at our domestic biopharmaceutical manufacturing resources, as we, again, noticed that we had some issues with foreign manufacturers and relying on that, especially during a pandemic, of product coming into the United States, wanting to spend some time looking at like, what do we have from an infrastructure standpoint here in the US? And then how can we expand on that and build on that so that we don't end up in the same situation again. All right, still federal, switching more from legislation to a little bit more regulatory or administration office, some things that are happening. So CMS, it was just announced that we're going to have more free COVID tests covered through Medicare B for Medicare eligible patients, and up to 8 of them free per month. What that's going to look like, how pharmacies get into that to be those, how they're reimbursed, how they're billing Medicare B, to be determined. I think maybe I heard that next week or the week after we might have some more specifics released. So if that's something that your pharmacy is interested in, or where you work is interested in that, be watching for that. I've also heard of some other people saying like, I'm out, I'm not going to volunteer. So just know that this is happening. There is rules around that 8 per month, and we'll see what happens because it's Medicare B, so billing federally, and we'll see where that goes. They're also looking at, so this Patient Protection and Affordable Care Act. So they're looking at this through 2023, and what this is for essential community providers, so for qualified health plans, where right now at least they have to have 20% of their population qualify as an essential community, or to be an essential community provider. At least 20% of their patient base has to be predominantly low income, medically underserved individuals. They're actually looking at increasing that to 35%. So if that is where you work, kind of falls into that category, know that it is going to increase to 35% to meet that qualification. FDA, we have, over the past 2 years, I think we've all learned what EUAs are, and that they keep kind of coming as we need things before they go through the FDA. So again, we have an EUA for an antiviral pill that was put through in December of this last year. That first kind of oral therapeutic went through. And so know that there's likely going to be more as things go through the more slow process of getting approved through the FDA. And then we're just kind of tracking this next one. So this was actually proposed in February of 2021 about bubble packing opioids. And there's been a lot of public comment. Most of the national associations have all put comment in, and many states have tagged on to this as well, of recognizing that while we completely understand there's an opioid crisis, that like community pharmacies, and anytime they get a prescription for an opioid, having to then blister pack or bubble pack that into 5, 10s or 15s, how's that going to work? Like, it doesn't always fit with Q4 to 6 hour dosing from a quantity standpoint. And who's paying for the bubble packs, and there's lots of issues, right? So while there's some good intentions behind it, devil's in the details, as they always say. And so we're just kind of still tracking that one to see what happens with it. DEA, oh my gosh, I'm trying to think. There's a couple of people in this room who have asked me this question. Can we transfer C2s now? What's up with what's happening with C2s? Can we, can't we? Somebody says yes, somebody says no. So I think we talked about this a little bit last year for those that attended, but the DEA had clarified that while a transfer by name is typically something's been filled and then you're transferring remaining refills, C2s don't count for that, but they also recognized as they're pushing to e-prescribing of C2s that sometimes it goes to the wrong pharmacy or the patient can't pick it up there and they need it to move. And you don't have a hard copy to hand them and say, take it to another pharmacy. So they have allowed the transmission of an original e-prescription to another pharmacy with a caveat that, and this is kind of through their policy now, and then they're in the official rulemaking process now to make it official and have it be codified as a CFR. It has to maintain the e-prescribing validity. So the security measures, you know, as you're receiving an e-prescription, that it's gone through that two-factor authentication, you would have to be able to send it with that if you're sending it to a facility that's not like your own facility with a shared computer system. So if you work somewhere that has a live computer system where this pharmacy, that pharmacy, everybody is on one system, that's actually not considered transferring it. So a lot of the larger chains have systems like that. Some smaller ones do as well, but it's just, are you filling it here or filling it there? You're pulling it from that same authenticated e-prescription, and so you're fine. But if you work for two different companies, you would have to, at your pharmacy, be able to send it with two-factor authentication and retain all of that. And most computer systems that I know of in the pharmacies are set up to receive e-prescriptions, but not send with those two-factor authentication pieces still maintained. And so while it's great that they're working on this, it really doesn't do anything for those people that have to go between two different facilities. Because unless your computer system gets to that point where you can actually submit an e-prescription as like the sender or a second sender, because the prescriber is the original. It's complicated, so, but they're in the rule process working on it. There's some proposed telepharmacy rulemaking. Again, this goes back to that Ryan Haidt Act. They're considering, so it's in rule right now, they're considering telepharmacy registration. Because of that, using the internet to dispense controlled substances. So if you have a telepharmacy, does the Ryan Haidt Act apply if, say, you know, I'm in Moses Lake and I'm filling a prescription and then it is electronically through the internet sending it and dispensing it in Royal City? How does that apply? So there, as telepharmacy and telehealth has expanded quickly, it expanded a lot faster than the rulemaking process, especially with the DEA. And so they're trying to look at this and create some rules so that they're not hindering practice, but also making sure that there's some protection measures in place. And then we also have the proposed MAT Act. So that data waiver, so the XDEA, if you are prescribing for patients for opioid addiction, and pharmacists couldn't get an XDEA. We can have a DEA number, but there was restrictions to get an XDEA. There have been in the past, they recognized that there was a barrier to care. And so previously they put in an allowance for if a provider has, I think it's less than 20 patients at any given time that they're using that X waiver for, then they don't have to have it. If they go beyond 20 active patients, they did have to have an X waiver. So they're looking at potentially just getting rid of it completely. And then that would also open the door for pharmacists who are involved in prescribing through a CDTA, opioid or other medications, to not have to have that restriction of not being able to do that practice because they don't have that X waiver. So they're in the process of that rulemaking right now and still taking stakeholder input on that as well. All right, so I think I have my first lecture Panda question. I bet any of those people that are still paying student loans were listening when I mentioned this. So in the Strengthening the Public Health Workforce Act bill, what would the new annual maximum for student loan repayment be for qualified public health providers? So your options are 25,000, 35,000, 50,000, and 80,000. Yeah, looks like most people have put 50. That is true. It's currently the second was 35,000. That's what it is right now. And so they're looking at moving it to 50,000. Really, we have a shortage of providers everywhere, but in rural communities, it's even worse. So they're really trying to entice those people to go out into rural communities and also be involved in qualifying public health service facilities as well. And with as expensive as pharmacy school is right now, that probably wouldn't be such a bad thing. All right, so we're done with federal. Let's move to the state because we have a lot going on in our state and we have 15 minutes. Oh. Do ARNPs, can they e-prescribe? Yes, like, and no, ARNPs in Washington state have equivalent authority as an MD or a DO. Other states, some of them have some limitations, and we have a question online. Oh boy, I need a tax attorney. Is the forgiveness taxable, a taxable write-off? I do not know. Does anybody know? Bill knows. Oh. You have a different question? Okay. I don't know the answer to that, so I'm sorry. Buddy Carter from, yeah. So for those online, Bill Fassett was letting us know about a bill that dropped federally. It was introduced into legislation last week that ECAPS, I think, was the shortened version of it that you said that would allow for payment and reimbursement for pharmacists at the federal level. Okay, so it's tied to, it sounds like it's tied to some of the things that we've had with COVID, with the reimbursements that we had through COVID, and with knowing that some of the, like the PrEP Act and CARES Act would be ending and making something a little bit more permanent. So that we'll add that to our tracker. I haven't had my government affairs committee meeting for APHA since last week, so it'll probably be on our next meeting. I am looking forward to reading it. Okay, so that was a lot of federal stuff, and I still have quite a few state things to go through, so I'm going to kind of whiz through some of these pretty quickly. I'm super excited that because this was a short session, it wasn't a full budget, but a supplemental budget. University of Washington and Washington State University's pharmacy programs came together and said, let's go together and ask the government for money to help with behavioral health. We both need a specially trained behavioral health psychiatric pharmacist faculty, and we have 0 PGY2s in psychiatric pharmacy in our state. So all of the people who do this go out of state. And so we did get the funding approved so that we can each hire a faculty and then each have enough money to start 2 PGY2s in psychiatric pharmacy. University of Washington is focusing more on urban provision of care, and Washington State is looking at the rural providers and rural provision of care. So we're just really excited that that money was approved, and we look forward to hiring people soon and getting that all going. Yeah, right? Woo. If any of you are clinical psychiatric pharmacists looking for work, be watching for some job postings. So state legislation. So we got a few things through this year. I feel like anytime in Olympia, they don't know what to do with something, they just create a board to talk about it for a year. So that's kind of what happened with this one. So the Healthcare Authority has to, do some rules and have this prescription drug affordability board that's already there. And previously they were monitoring drugs who had been on the market more than 10 years. They modified it to 7 years so that there was more products they could look at, setting upper payment limits. And so really it was just kind of a modification to this prescription drug affordability board. While I would always like more action, usually the more people like peeling the layers of the onion get to the core of the onion, which is probably a little bit more of what Brandy Signamartin's going to talk about a little bit later, which is like why are prescription drugs actually so expensive? And that usually has to do with the middle, right? And so, like I said, I would have liked to have seen a little bit more action with it, but looking into it can't be a bad thing. We had legislation in 2020 that went into effect January 1st of 2021 that capped insulin copays at $100 a month. This session, knowing that that was going to end at the end of this year, this legislative session, they had a bill go through that reduced that to $35. And that will start January of next year. When the current $100 one ends at the end of this year. So we'll just be kind of watching that. And then I'm just kind of curious, any of you in your practice settings, because it started January 1st of last year, so you've had a year and a few months, has anybody actually seen a prescription that capped at $100? You're filling a prescription for somebody for an insulin product and the copay was $100 because it capped out. What is it, the insurance company that's going to cap it out? It would have to be, right? Because it's on that copay side. So you're filling it and it came through and their copay was exactly $100 and would have been more otherwise. So far I have one yes and that's it. Most no, most, some I'm not sure, or this, a lot of like me doesn't apply to my practice, but a lot of no's. So that's kind of why they spent time this legislative session reducing it to $35. Because they got feedback of like, most people's copay is below $100. And maybe you're going to impact them at the very beginning when they have that high deductible plan and they are paying all of it out of pocket. And so that's really why they spent some time this year reducing it to $35. But again, that doesn't go into effect until next January. So hopefully, if this question is asked again, a year or 2 years from now, you'll have some yeses that we finally got down to that dollar amount that it's actually helping people. In our state, we had a bill last year that went through, but it doesn't actually start until next January. So it's, some people really haven't heard of this yet, but it's really allowing for the home of the patient, again, to be an approved site of the origination of care. And previously, if you did telehealth versus an in-person visit, the provider got a differential payment. It was lower if it was through telehealth. And so it actually made it to where the care had to be reimbursed at the same rate. Again, though, it does still require in the state that there's an established relationship within that past year of that patient. So they don't want the initial visit of establishment to be through telehealth. So they can move to that audio. If it's audio only, so if it's like a phone call, they have to have an established relationship. If it's audio visual, this didn't apply. So back to that, we're going to allow some of that like Zoom or Teams healthcare appointments. But if it's the phone call telehealth, there has to be a previous relationship established. I'm gonna assume, yes. The insulin copay? So the questions about that $100 and then this legislative session in Olympia, they changed it to $35. That's for private or commercial plans. So it doesn't impact Medicare because that's federal. And it didn't impact Medicaid because if you understand kind of how Olympia works, if anything has a fiscal note or there's dollars attached to a bill to implement it, like somebody's going to have to look at something and do something. Yeah, and Medicaid copays, the patient usually doesn't have a copay, but they usually don't have anything apply. They also didn't specifically put in some of like the state employees and things like that because it could have cost money to implement and then it could have made the bill die. Yeah, self-insured companies because they fall under ERISA federally. And so that has another complicating factor as well. So it's really those true like commercial private plans in Washington state. Definition of compounding. I'm waiting for Jenny Arnold to like do her happy dance. We actually have a definition of compounding now in our state that matches the federal compounding language. Is it 100% perfect? No. Is it a heck of a lot better than it was? Yes. So if you think about now, like the reconstitution of those powder antibiotics, or if you have Capex shampoo and you were, you know, per the label, you had to take the little capsule and mix it into the shampoo bottle, right? The medicated shampoo. You now, in the old rules, were compounding and you had to follow 795 USP standards, right? You probably needed a powder containment hood to open that one little capsule and mix it into the shampoo. So thankfully, we now have a definition that says it does not include reconstitution or mixing if it is part of the FDA labeling that mixing is required. And so that's that piece that you have to watch because some of those kind of compound in a box that goes to pharmacies, there's a couple that actually have gone through and got FDA approved, but many of them are not. And so if they're not FDA approved and you're mixing 2 or more ingredients, then you would have to comply with USP 795. And then the substitute Senate Bill 5169, I just added because if any of you are medical billing, you're providing care in your medical billing, just remember that if, especially due to COVID, if you're using additional PPE, there's a CP2 code you can be using and get some reimbursement for that PPE that you're using in that setting. Oh, we had some stuff that we were sad to see die and some stuff, some of us were kind of okay with seeing die. And so I just want to spend some time so that you know kind of what was being pushed this past legislative session at the state level. We really tried to get a pharmacy choice bill through. So not saying there can't be mail order, but saying patients should choose if they want to receive their medications through mail order. They should be able to pick a pharmacy of their choice if that pharmacy contracts and accepts the reimbursement rate. The Senate bill never went anywhere. It didn't, it got assigned to a committee and it could have just went straight to the trash. In the House, it actually moved along. We had a really good hearing in the House Healthcare Committee. It went to a floor and it actually passed the House floor unanimously. There was 3 absentees, but 0 no's, unanimously passed the House, right? So then it moves over to the Senate and gets assigned to the Senate Health and Long-Term Care Committee, never got a hearing. And so it was a little bit frustrating. We have some work to do with some of the people on that committee and the committee chair as we want to keep trying to push some of this in future years. but it's a little frustrating. And then just know there was also this companion bills around prescription labels. It was a group of students as part of a health equity circle, mainly at the WSU Health Sciences campus, but they had some people from UW as well. Students with good intentions that were looking at requiring that prescription bottle label, so not just labeling like the paperwork, but the actual label, have full translation, but also have full English and the translated language. And we were recognizing that there's going to be some issues with a lot of companies like labels, and if they're using zebra printers or the big label, like there was going to be some work that needed done. We were really happy to see that PQAC recognized that they already had regulatory authority to write rules around labels. And so they actually opened a CR 101, or to start the rulemaking process around prescription labels in our state. And so we were able to get those in Olympia to realize that these bills really weren't needed, because really they were telling the commission to start rules on this, and they were already doing it on their own. And so that bill died. That's usually a good thing, because if you get too many details in statute, then you're stuck in the rule. So having PQAC work on this, I think is going to be a little bit better. So just know you need to be involved. You need to be watching for that. If you're thinking that this could impact your practice, or if you have a lot of patients that are English second language, or English isn't a language, you're going to want to be involved in that rulemaking process and helping to shape that. And we're just about done. This is kind of leftover. We've already talked a lot about the new rules. I don't know how you might have gotten this far and not known that we have new rules. Hopefully you're all aware that we do have new rules. Again, wanting to just point out the two things on the bottom, that there were some changes to the monitoring of drug therapy definition. And there's a little bit of concern around some of the language there. And so we're hoping that as we have less interim folks at the Pharmacy Commission, we can bring that up at a commission meeting and potentially look at addressing some of that. And then there's a new section on CDTAs. And then just as kind of, I think one of my last things, a reminder, the Medical Commission filed rule writing a CR 101, but this was back in July of 2020 around CDTAs, and we were really worried this was going to be really restrictive. Just know that that's still open. They did take input from the Pharmacy Association, the Medical Association, hospital, pretty much everybody except the Medical Commission went to them and said, what are you doing? Slow down. And so they kind of paused, and they haven't moved through that rulemaking process, but they also haven't rescinded their CR 101. And so it's still there, sitting there. And so we're just kind of monitoring that and want you to be aware of that. And then lastly, knowing that our Pharmacy Commission, there's representatives speaking later, but at their meeting just last week, they again extended they're not going to enforce USP 800 at least now until September 30th of this year, because they still recognize that there are discrepancies. That's the USP 800 is for hazardous drugs at the federal level. They recognize that there's discrepancies with 797, and they also require you to be 797 compliant. So if you're compliant with one, you're in non-compliance with the other. That causes some issues. And we also, for years, have had our own L&I handling of hazardous drugs rules in place that we have to comply with. And 800 also doesn't play nice with those. So if you comply with one, you're in non-compliance of the other. Just a reminder, 825 radiopharmaceuticals, that's pretty rare, but they are already expecting that. They have resumed their inspections, so make sure they kind of paused that with COVID. Make sure you're doing your self-inspection every March. If you have a change in responsible manager, it has to be done within 30 days. They've also kind of extended the waiver for providers for mandatory e-prescribing for them to put in for hardship. The key thing to take away from that is, as the pharmacist, if you get a C2 prescription and it's not e-prescribed, It's not upon you to figure out, does that prescriber have the waiver that allows them to not be e-prescribing? It's on the prescriber. And so if you are getting those, I know this is going to be kind of hard for a while because it's going to be ingrained in us of like, they all must be e-prescribed, right? But if there are waivers out there and we have been told pharmacists are not going to be held accountable for like checking waivers. It's written in the law that pharmacists, it's not their responsibility, but company policies might be different, right? We see that a lot. So where you work might take a different stance of like, we don't want anything if it's not e-prescribed, but there are waivers out there. And then if you're doing telehealth, you need to make sure that you do the telehealth training. There's a link in there if you need access to that. And so I think we just have one last question. So the accrediting body for CEs is happy with us. So must you comply with 797 if you are reconstituting? And the majority of people have said no. All right, so that was fast and furious, federal and state. Read this list, get involved, join the WSPA legislative committee, get involved if you want, or just be a member to help pay for Dee Dee to go fight in Olympia for us. If you don't want to fight it yourself, she's really good with the boxing gloves. So I know we're a tad over. Any questions?
Thank you, Dr. Akers.
All right.
Another rapid fire recap. Thank you. The code for this session is LILAC. L-I-L-A-C. Oh. All right. Well, off of some regulations and laws and on to more, it's my pleasure to introduce our user's guide to pharmacy benefit manager laws and third-party companies. It's my pleasure to introduce Brandy and Dee Dee. Brandy Signa Martin graduated from Washington State University College of Pharmacy and Pharmaceutical Sciences, and then went on to complete an executive fellowship at the Washington State Pharmacy Association. Her interests lie in advocacy and pharmacy policy and regulatory innovation and independent pharmacy experience. We lost her though. She now serves, and we're proud of her though, too, I should add. She now serves as the executive director for the Alaska Pharmacists Association and faculty at the University of Alaska Anchorage and Idaho State University Doctor of Pharmacy program. Dee Dee Little is the Director of Government Affairs at the Washington State Pharmacy Association since 2004. Prior to joining WSPA, she was the Director of Government Affairs for the Washington Retail Association. Dee Dee has been a registered lobbyist in Washington State since 1990. During her career, she has represented agriculture, timber, small business, big business, and healthcare. She studied political science at Evergreen State College. Welcome, both of you. Thank you. Pull up your slides.
Perfect. Is there a clicker? All right, thank you. Hello, everyone. It's very great to be here today. I'm Brandy and the lovely Dee Dee over here. Yes, we also have no disclosures, but again, like Dr. Akers said, if anybody wants to pay us more money to do this work, you know, We're very happy to. We're really the objectives of this discussion today is to kind of talk through what are your rights in respect to actions by pharmacy benefits managers. And we really wanted to take the approach to kind of step back a little bit and understand some of the different insurance types and how, what you see in the pharmacy might sometimes bump up against what you hear about is in a law. And it's because insurance codes are extremely complicated. And as in Dr. Akers' talk, they're regulated at a lot of different levels. And I apologize, I'm recovering from a cold a couple weeks ago. So really, let's start with talking about the different plan types and how they are regulated and how that might impact what you see as far as regulation versus what you see in the pharmacy. Like using that insulin example with the cap, even though there's this law that says there's a cap of $35, you could still in the pharmacy see a claim come through where there is a copay that's higher than $35. And that's going to be that differential where it's possibly a plan that's not regulated by the state of Washington, such as a commercial health insurance plan. So our commercial health insurance plans, those can come through your employer if your employer purchases a commercial health insurance plan on the market, and that's what they offer to you. It can also come by actually you purchasing a plan or a person, purchasing a plan on the market personally as well. We have the self-funded insurance plans, and that is when the employer actually is paying for all of the healthcare claims on the back end. So a lot of our large employers are actually providing self-funded plans. Now, when you're in the pharmacy or you're looking at someone's insurance, you don't always know where the funding is coming in on the back end. Occasionally you do. I've seen sometimes in the pharmacy where someone brings in a card that says like they're an iron worker and this is an iron worker union's plan or something like that, where you might know, okay, this is a union plan specifically. But oftentimes, whether you see that card or not, or you're just seeing the claim come through, this is a BCBS claim, but you don't know if it's commercial or self-insured. So oftentimes, unfortunately, when we're actually working with our patients, we don't really know, which is what makes it incredibly difficult to kind of, from our side, being the pharmacist, to work with the Office of the Insurance Commissioner to ensure that these laws are being enforced properly. Then, of course, we have our Washington Medicaid plans, both the fee-for-service as well as the managed care plans. And those are all purchased and contractually managed through the healthcare authority at the state level. I will say that a lot of the provisions I think all the provisions that have been passed into law, protections around pharmacy benefits managers, even though Medicaid is not legally required to have those protections in place, they contractually have adopted all of those protections. So anything that you see in here, even though it's not in the law, it is in all of the contracts that the healthcare authority has with their contracted plans. We also will see oftentimes that the PEB and sub plans they're kind of managed in their own way. They're really not subject to a lot of the regulations because they really are managing the cost on the back end since they're all purchased also through the state. So ERISA, as also Dr. Akers mentioned, the Employment Retirement Income Security Act is a federal law that really is set out to protect employers and also workers to ensure that there's kind of a base level protection for, it's a lot about pensions, but there's also about what healthcare is provided to employees. So a lot of those all those self-funded plans from our employers, they fall under ERISA. So they're protected by ERISA and they do not have to follow the state regulations. They do, however, have to follow some federal regulations as far as what coverage must be included in a person's plan. So there are a lot of things like, for instance, in Washington State, we adopted the Reproductive Parity Act in our state. And so, for instance, a plan has to cover 365 days of hormonal contraception at one time in the pharmacy. But that's, again, not going to apply to an ERISA plan. It's only going to cover like a commercial or state-based plan. So these are some of those things where you see, some of these discrepancies. And then, of course, our Medicare Part D plans, they're all regulated at the federal level. And unfortunately, none of the protections that we put in at the state level can be applied to the Medicare Part D plans. And then, when Dee Dee and I were making this presentation, we spend a lot of time talking about PBMs to each other and to other people. And so we're really familiar with who they are and what they do, and the ins and outs of that. But we kind of realized actually after we kind of turned in our slides that all of our pharmacists and technicians and pharmacy professionals might not be fully kind of aware of what is happening. So I wanted to back up a little bit before we move on and just talk a little bit about pharmacy benefit managers. So originally they were designed to kind of be this person who just handled the adjudication of a pharmacy claim, right? So that instead of a patient having to come in and pay cash and then submit for reimbursement to their insurance company, they would be able to have the claim adjudicated directly in the pharmacy and not have to pay that upfront. Over time, pharmacy benefits managers increased their, I'm putting this in air quotes, services that they provide to the health insurance plans. So they actually are a third party that is contracted to the health insurance plan to design all of the pharmacy benefits. They design the formularies. They work with the pharmaceutical manufacturing companies to work out rebate systems that essentially can earn their drugs, to get on a specific tier within a formulary, those types of deals that are happening. They also determine co-pays on the plan or any co-insurance. And so they really manage the entire design of the plans. So they've really taken on a much bigger role in not only that adjudication process, but the ultimate design of the benefit plan, and so on. However, since they're not the actual health insurer, they have up until the last 10 or 15 years, they have gone completely under the radar and never, ever been regulated. There is absolutely no regulation at the federal level for PBMs. And then in the states, it's really a patchwork of different things that has happened. And it's really, I think some of these started maybe 10 to 15 years ago, but increasingly over the last several years, we're seeing a lot more states trying to regulate pharmacy benefits managers because they play such a huge role in our healthcare, the healthcare costs to the patient, as well as healthcare costs to the state. So I'll probably try to talk a little bit about spread pricing, for instance, which has been actually against the law in Washington State Medicaid, but it's found in several states. You can just actually do a simple Google search and you'll find that in Ohio, as well as Florida, many claims have been assessed, and they find that PBMs frequently, they tell the health insurer, we paid the pharmacy $500, for instance, for this drug. But in reality, they paid the pharmacy $250 for that drug. So because they're in the middle, they end up keeping the rest. And that's that spread pricing piece. So there's a lot of different regulations that have gone into effect in different states trying to get at some of these different antics, we'll say, that pharmacy benefit managers have played to really take a lot of money out of our healthcare system. So when the laws that we're kind of going to be talking about here, and Dee Dee will get into in a minute, were passed and went into, and have just most recently went into effect, that was before the Supreme Court case Rutledge versus PCMA. So Rutledge is the Attorney General of Arkansas, or was. PCMA is the Pharmaceutical Care Management Association, so the association for all the PBMs at the national level. And in 2016, Arkansas passed a law trying to regulate PBMs in lots of different areas, but one of the key areas was on reimbursement. And they specifically said, look, PBMs cannot reimburse a pharmacy less than the pharmacy paid for the drug. That it just doesn't work. It doesn't make sense. It doesn't, there's no sustainability in that. Ultimately, there were lawsuits at the state level that went all the way up to the Supreme Court, and Rutledge won that Supreme Court case. So the Supreme Court said states can regulate ERISA plans around reimbursement specifically. So that's a really great thing. We unfortunately have not in Washington state been able to get to that point where we're regulating ERISA plans on reimbursement, but we now can because of that Supreme Court case decision. So in some of the laws that we're talking about in RCW 48.200, the exemptions are all for the PEB and SEB plans, any union plans, so a plan administered for and by union members. Medicaid, of course, except like we said, most of the provisions are there contractually. And then nothing, for Part D again, because those are all federally regulated.
All right, it's my turn. So as we were, we've the past, since 2014, looking at pharmacy benefit managers and attempting to regulate them, we've got some audit standards in law. So PBMs must establish a written process and procedure for a pharmacy to appeal claims findings and must provide notice to the pharmacy prior to conducting an audit. PBMs may not conduct an audit of a claim more than 24 months after the claim was adjudicated by the entity. Must give pharmacy 15 days advance written notice of an on-site audit. May not conduct an audit on-site during the first 5 days of any month without a pharmacy's consent. And must conduct the audit in consultation with a licensed pharmacist if the audit involves some form of clinical or professional judgment. May not conduct an on-site audit of more than 250 unique prescriptions of a pharmacy in a 12-month period, and except for cases of fraud. Oh, thank you. And so, what's a validation of a claim? It's an electronic or physical copy of a prescription, a valid prescription, if the prescription was within 14 days of the dispensing date, picked up by a patient or designee, delivered by the pharmacy to the patient or designee, sent by the pharmacy to the patient by a United States Postal Service or other common carrier, point of service register showing purchase, and electronic records, including signature logs, scanned or stored patient records, or any other documentation that corresponds with the claim. To continue, PBMs cannot conduct more than one on-site audit of a pharmacy in a 12-month period, must audit each pharmacy under the same standards as those similarly situated, and must pay any outstanding claims no later than 45 days after the date the appeals are concluded or the date a final report is issued. They cannot include dispensing fees or interests in the amount of any overpayment assessed on a claim unless the overpaid claim was not filled correctly. They cannot recoup a cost associated with any clerical errors or other errors that didn't result in any financial harm to the entity or consumer. And they cannot charge a pharmacy for a denied or disputed claim until the audit and the appeals procedures are final. And then we get to the reports. The PBMs must provide pharmacies with a preliminary report within 45 days. Pharmacy has 45 days to contest. There are extensions that can be considered, and there is the allowable, you can resubmit of claims denied or disputed for reconsideration. And then the PBM must provide the final report 60 days after its preliminary report. If the identified discrepancy for an individual audit exceeds $40,000, any future payments to the pharmacy can be withheld by the PBM until the audit and the appeals procedures are final. So Brandy's going to talk about the fees and activities.
All right, so really this was a big part of 5601 and that is now in the law and actually just went into effect in January 2022 because it takes quite a while for the plan time to turn over. So usually when a law passes about an insurance plan or what's contractually required, it has to go into effect usually at least 1.5 to 2 years later. Sorry, because they have to actually create the new plans and then be able to implement them in the upcoming plan year. So some of the provisions are around, PBMs, some of the things that they do, they are able to communicate directly with patients, the patients that they serve through the health plan. So we really want to make sure that they're not knowingly advertising or promoting in a way that is misleading. We already know that patient steering is a huge issue, and that's what we were trying to solve during this most recent legislative session that unfortunately didn't get passed. But besides where there is oftentimes required patient steering to a mail order, all right, but there is a list specifically in statute that provides some specific things they cannot charge a fee for. And then also there's a good description. So really trying to get at describing ways that they can't charge fees, even if they call it something else. So they can't charge a fee for an adjudication of a claim. There's also a description in here about, they can't charge any fees related to processing of a claim. So even if they try to call it something else, we're trying to get at the fact that they can't charge a fee for us to be able to serve their patients, which requires, of course, a claim to be adjudicated.
I've definitely been hearing from independents who are looking at their fees and seeing fees, and we're aware that this may not be being enforced at the moment. And so we're working on how we challenge that and go forward and work with the Office of the Insurance Commissioner. So I know that the reality of what you see may not be what this is at the moment, and it just started being implemented. So we'll play whack-a-mole.
Yes, and definitely if you are privy to seeing what's in your contracts or what fees are being charged to the pharmacy, reach out to Jenny and Dee Dee, and they're trying to gather information so that they can work with the Office of the Insurance Commissioner and try to figure out how this can be enforced. So, communicating along, with our community is a really good thing here. But really trying to get at that the PBM shouldn't be charging the pharmacy for participating in the network or accreditation or anything like that. Sorry, I lost my pointer here. All right. They also cannot require accreditation standards that are inconsistent with or more stringent than accreditation standards by a national accreditation organization. And this comes about because oftentimes PBMs were putting onerous accreditation requirements on pharmacies far beyond what is recognized professionally at the national level or a state level. So trying to kind of protect pharmacies from having to pay a lot of those additional fees that also often go along with those higher accreditation standards. PBMs may not reimburse a pharmacy in the state in amount less than they reimburse their own affiliate for pharmacy services. And this is one of those things I told you, there's been many reports out of Ohio and Florida where they've actually done Freedom of Information Act requests. And like in Florida, they looked at 350 million de-identified Medicaid claims. And they find time and time again that the PBMs are reimbursing their own owned pharmacies. As previously stated, they frequently are steering patients to those pharmacies. They'll pay them 10 times plus what they pay a local pharmacy, especially independent pharmacies, has how those reports showed. So really trying to get at that and making sure that they are reimbursing our local pharmacies and pharmacists adequately and the same that they reimburse their own pharmacies. Again, this is one of those places where this could be applied essentially to the ERISA plans based on the PCMA court decision, but we're not there yet. So more work for everyone here to be doing. They cannot basically claw back. So directly or indirectly, retroactively deny a claim or reduce a claim. So those clawbacks, they cannot do clawbacks. Unfortunately, this doesn't touch DIR because that's Medicare Part D. So that's definitely a bigger issue for us all to be involved in. There is a proposed rule for Medicare Part D and DIR fees right now. So definitely keep track of that and we'll keep working on that at the federal level. And then really just trying to get at that they can't take anything back unless it was for some reason that was a fraudulent claim or there was an audit involved and money was taken back because of that.
Okay, so I'm going to talk about other contractual requirements in addition to everything that we've been talking about. As we were looking at drafting our legislation over the years, and we'll talk about all the 3 bills that we've been working on, it was really important to address the PBMs and the lists that they provide to you folks and the pricing lists. So PBM may not place a drug on a list unless there are at least 2 therapeutically equivalent multi-source drugs or at least 1 generic available from a manufacturer that's generally available for purchase by network pharmacies from a national or regional wholesaler. Because what we were finding is when businesses were pushing back, when pharmacies were pushing back and saying, hey, this reimbursement isn't fair. And they're like, well, we have it on our list, and the list would come from Tennessee. And so we really narrowed this language down that says you have to have a list that the pricing applies to Washington pharmacies. And then shall ensure that all drugs on the list are readily available for purchase by the pharmacies who operate in Washington and who get their drugs from national regional wholesalers that serve those in Washington, and the drugs cannot be obsolete. Let's go next. So additional contractual requirements. PBMs shall make available to each network pharmacy at the beginning of the term of their contract and upon renewal of a contract, the sources they use to utilize to determine the predetermined reimbursement costs for multi-source generic drugs. Now that's a mouthful. And we initially, when we put our first bill together, we were looking at using MAC, the maximum allowable cost. But what we've learned over the years is that the pharmacy benefit managers are very sly, and they find loopholes and they find workarounds. And so we tried not to specify MAC in general. So we came up with predetermined reimbursement costs for multi-source generic drugs. So you're going to see that throughout the PowerPoint as we refer to these lists. PBMs shall make a list available to the network pharmacies upon request. They must update each list the PBM must update the list every 7 business days and make those updated lists, including all the changes in the prices of the drugs available to network pharmacies. And they cannot include dispensing fees in the calculation of their reimbursement costs. Okay, so appeals process. So as as we were dealing with this, the pharmacies were talking about, hey, how do we do this appeals process? The PBMs all have these different various appeals. Some don't even have it. So we created in law that a PBM must establish an appeals process for network pharmacies to appeal its reimbursement for the drug subject to the predetermined reimbursement costs for multi-source generic drugs. A network pharmacy may appeal the reimbursement for a multi-source generic drug if the drug was less than the net amount the pharmacy paid to the supplier of the drug. So if you were getting paid less than what you bought the drug for, you could file an appeal. The appeal must be completed within 30 calendar days of its submittal. And if after 30 days, the network pharmacy has not received a decision of appeal, has not heard back from the PBM, the appeal is considered denied. So then we were looking at, okay, so let's have a second tier. Okay, we're appealing to the entity that is they can just ignore us. And so there was no other, other option. And we started out this appeals process to apply to all pharmacies in the state. But as politics and how things work out, they said, listen, okay, if you guys want to do this, let's apply this to small pharmacies. So we created the small pharmacy reimbursement appeals. So the small pharmacy reimbursement appeals can be submitted to the insurance commissioner office by their website, requesting the insurance commissioner to review a PBM's decision regarding the reimbursement of a drug, as long as the appeal is filed by a pharmacy that has 14 or fewer outlets in Washington, the prescription was filled in Washington, the prescription was filled for a patient covered by a fully insured non-ERISA plan, the prescription was for generic multi-source drugs, and that the small pharmacy had utilized the PBM's initial reimbursement appeals process. So they had to go through the PBM's appeals process in order for the second tier to kick in. And the pharmacy had been issued a denial or it was unsatisfied with the reimbursement for the cost of the drug overall. So then we had to set up this process, and Brandy's going to go into how to file, but eligible, kind of just going back, eligible pharmacies can submit information to the insurance commissioner office about an appeal. So we put this under the insurance commissioner's office because they oversee all the carriers, the health plans, these guys, it just made sense for these guys. At first, they didn't want it, and I'll talk a little bit about that, kind of the evolution. They didn't want this, but when we passed this bill, 5857, that created the small pharmacy reimbursement appeals process, we took the opportunity to educate the insurance commissioner's office on PBMs. They didn't know they even existed. And here you have an entity that is making, basically setting the cost of prescription drugs, impeding access, and really impacting consumers. And so we took this opportunity to use it as an education process with the insurance commissioner's office after we passed this law that directed the insurance commissioner to create this process. So the commissioner authorizes the Office of Administrative Hearings to conduct review of the appeals process. And if it's upheld, the PBM shall make a reasonable adjustment within 1 day after its determination. And then we had to put in, PBM can't retaliate against a pharmacy for pursuing an insurance commissioner review of appeal. I mean, we've had to put in these, again, we had to put this in law because these guys would, they would harm an independent pharmacy in retaliation for filing a complaint. So we had to put that in law so we could hold them accountable. And then Brandy's going to talk about how to file a small pharmacy reimbursement appeal.
Yeah, so you can access this link actually through the documents that are shared via Lecture Panda. But also if you just Google Office of the Insurance Commissioner, Small Pharmacy Reimbursement Appeals, you can find all this information and the link to actually file the petition there and kind of read more about the process. So it has to be an acting representative of the pharmacy. And so that's either a manager or it could actually be a person who is a legal representative of the pharmacy. And then before the appeal is even filed, really all of the documents need to be gathered. So make sure that you get everything that was a part of the original appeal to the PBM, the invoice for the drugs, the MAC list, the current MAC list for the PBM is required as part of the appeal. Their determination. So as Dee Dee said, you know, if they don't respond in 30 days, that's also a determination. So just documentation showing that you filed the appeal was filed, but it was never responded to within the appropriate time frame. And then what's really important, what we've heard from people who have been successful with these appeals, is really the other support documentation. So showing, you know, contracts with secondary wholesalers, for instance, citing that if say on the MAC list, even though they are supposed to only have drugs on that list that are accessible to pharmacies in Washington state, we actually find that that's not always the case on the list. So the people who have been very successful with these small pharmacy reimbursement appeals is that they're able to show, you know, through their main wholesaler, they're not able to buy the drug at that cost. And then also even through a secondary wholesaler, maybe the drug alone could be at that cost, but the extra fees, because they're a secondary wholesaler or something, would actually increase the cost of acquisition overall. So any documentation that you have that can really make your case for why the acquisition price is more than what they're allowing is going to be really, really helpful in the case overall. And then submit all the documents. I heard from some pharmacists that it wasn't really clear at certain points during the process what documents to provide when. Provide all of the documents at every step. So when you file the petition, like through this link, or once you go to the page on the Office of the Insurance Commissioner's website, there will be a place to submit documents there. And then you'll be contacted by the Office of Administrative Hearings from the state of Washington. It's actually an administrative judge who oversees the hearings and makes the determination. So at that point in time, when you get contacted about having a hearing, also submit all of your documents again at that point in time, just to make sure you're closing the loop and that the judge who's making the determination has all of the information that they need to be able to make the determination, hopefully in your favor. So the judge reviews all of the documentation, and then they also will have a hearing where you will get to come join the hearing, of course. From what I've heard from many pharmacists who have also been successful in this, the PBMs don't always show up. So that gives you the chance to show up and make your case, hopefully really well. And one of the things with this, especially if, say, on that list, on their MAC list, if they did have that drug from Tennessee that's from some wholesaler that you can't get in Washington state, in the WAC that actually goes along with these laws, there is the enforcement mechanisms of fines. So a fine of $1,000 every time that a PBM is not following the law. And it could actually be up to a $5,000 fine if you're able to show that they willfully and knowingly did not follow the law. So each time that one of these is filed and it's successful and they're doing something wrong on their end, like not putting the right drugs on the list, that could end in a fine for them. And we really want to work with the OIC and make sure that we're really showing that the PBMs are acting in bad faith and they're not following the law, because this can hopefully help our case going forward, as we really need to build more regulations around PBMs to protect our patients, as well as to protect pharmacists and pharmacies in Washington state. There's also a new provision where we can actually file complaints against PBMs for, not an appeal to actually get more money from them, but just complaints that they're not following their contracts. And it's a little bit unclear right now about what that process is going to look like. However, part of the law that just went into effect in January is that PBMs must file all of their contracts with the Office of the Insurance Commissioner. So that's their contracts they have with both the health insurance plans as well as with each individual pharmacy. So if you can file a complaint, and hopefully that process will be up and running soon, but the OIC could actually go and look at the contract themselves and possibly be able to make determinations on if the PBMs are following their contracts. I mean, and ultimately, my hope is that eventually they can start seeing patterns of unfair contracting, because oftentimes we know that, the pharmacists and pharmacies don't really have much say in the contracts and what is actually in them. And now Dee Dee is actually going to walk us through one of the, I think, really important parts of kind of understanding this bigger picture is how we've gotten from point A to point B to point C and actually built some regulation around the PBMs.
Yeah, so, I started tackling pharmacy benefit manager legislation back when I was with the Retail Association. 25% of my time was spent overseeing a retail pharmacy council. And they quickly brought it to my attention. I quickly learned about the pharmacy benefit managers. And we started running, that's when we first started running legislation. And our first bill was any willing pharmacy provider legislation. And we focused on that when I think we ran a light touch on mail order. But what we learned, and it was tough because our focus was on the health plans at the time. We were trying to get at the PBMs through the health plans. And we were unsuccessful. And then so we finally realized, okay, we need to start drafting our legislation that's specific towards the pharmacy benefit managers. And so this is where, the challenge has been, and, we're making progress, but it was really hard to explain to a lawmaker what is a pharmacy benefit manager and what's their role. The carriers and the PBMs really enjoyed the fact that, trying to explain the PBM's role, because it is so complex. Pharmacy is complex, reimbursement is complex, drug supply chain is complex. And so they really took advantage of that for several years. But the first bill that we were successful in passing in 2014 was in Gross Substitute Senate Bill 6137. And this established the PBM registration within the Department of Revenue. It created the audit standards I gave you the review over, and establishing the MAC lists and the updates and notification and transparency requirements. So we initially wanted the PBM to be within the Office of Insurance Commissioner, but at the time they didn't know who they were. They didn't want it. No agency really wanted it. So the lawmakers decided, okay, let's just put it under the Department of Revenue. So fast forward a couple years, the PBMs were just ignoring it because there really wasn't any enforcement. It was like, okay, we got to file a registration and pay $200. Okay, and some of them just didn't do it. So we went back to the lawmakers, and lawmakers don't like to pass bills that people ignore. And so we just went back and said, hey, listen, these guys aren't doing it. The insurance commissioner's office at that time, we had started having conversations with them, educating the insurance commissioner's office about these guys, and said, hey, you guys might be really interested in this. And so they agreed to say, okay, move the registration over. So we introduced 5th in Gross Substitute Senate Bill 5857. And I want to point out the 5th in Gross Substitute Senate Bill. That's a first in Washington State, a bill that was amended 5 times on the Senate floor. It was quite a battle. But what we did was we moved the PBM registration over to the Insurance Commissioner's office. We established the small pharmacy reimbursement appeals process, made some changes to the MAC and updated the multi-source generic drug definition to the appeals process. And then we started putting some teeth into it. We allowed the OIC to financially penalize the PBMs if they were found in violation of a claims reimbursement. And this is under the small pharmacy reimbursement appeals process. So we put that together, and during the interim, when the insurance commissioner's office was creating the small pharmacy appeals process, we put together a group of WSPA members, pharmacy owners, who came down for an entire summer and met with the insurance commissioner's office to talk about and help them, create this process. They also met with the PBMs, but we took this opportunity to start telling them and educating them about the PBMs and about their role and the significant impact they were having. And so it really caught their attention. And so, we're moving along with 5857, trying to make sure that, people were aware of the small pharmacy reimbursement appeals process, but still running into issues with the PBMs overall, because the OIC had limited authority, and it was really over the small pharmacy appeals process. So as we were, we caught the attention of the insurance commissioner's office. A group of other, lobbyists came to me who represented several provider groups and said, hey, there's other healthcare benefit managers out there that are similar to the PBMs. I've watched you over the years try to fight these guys. Do you guys want to come together and create a coalition and approach this in a broader way? And I said, absolutely, because for years, it was just the pharmacy association. It was pharmacy against the PBMs, and it was just a battle royale. And we were just making small steps. We were making steps, and that's the good thing, is we were getting things passed and things in law that we were able to refer to. But it was real important. I mean, there was more to do. So we created WSPA co-led this, was co-lead of this coalition. We worked with the insurance commissioner's office. They provided technical support, and we created Senate Bill 5601. So as Brandy alluded to, this bill, we created the definition. It's the first of its kind in the country, healthcare benefit managers, to include PBMs. And so it we gave OIC clear authority over certain PBM practices, requires carriers and the PBMs to file all their contracts with each other and providers with the OIC, and then prohibits, as you saw, some specific PBM practices. So we've essentially moved all the PBM laws into one chapter of law. We still have some work to do. We've discovered some definition issues, and this isn't over, but we have something to work off of. We've got a baseline now, and so we'll continue to work. We continue to hear from our members that this is a big issue. Their livelihoods are at stake. The PBMs completely unregulated on a federal level. Washington State was one of the first to pass the registration. And a number of states are starting to do, as Brandy said, just kind of a patchwork approach, because we can't wait for the feds to do something. We've got to do something on a state level. So we've got some more work to do. We'll continue to do the work, but this is what we have right now to work with. And, we'll just continue to just try to fight this fight with these guys. Are we running out of time? Okay.
Yes.
Sorry.
Sorry, we can talk
But
about
there
this
is
all
some
day.
self-assessment questions on there that Mylyn will launch. And I swear we could talk about this all day long. One thing that I think is important to highlight as we talk about workplace wellness and pharmacists and taking care of our pharmacists and our pharmacy staffs, the PBM regulation ties to that in our mind. Pharmacies are not being paid adequately for providing the safe, essential care that they provide. And we have to make sure that that reimbursement is in the right place, reinforced in the right way, so that we can staff in a safe way, so that we can support our pharmacists. I don't think that fixing the PBM laws alone is going to fix where we're at, but I think it's an important element. You sure aren't going to get more staffing if you don't fix the payment issue and the reimbursement issue and make sure that that's in the right place. So that's why this is so important to us. From the business of pharmacy, it ties to patient care, it ties to patient safety, it ties to pharmacy staff, our pharmacists, our pharmacy technicians, interns' well-being in our mind very directly. So I just wanted to highlight that. Thank you, Dee Dee, for going to bat for us in Olympia year after year. You're a tremendous asset. I know this year was rough and we really appreciate it. Brandy, we're missing you already, but wish you the best luck. And we know you're not far away in Alaska. And we'll be continuing to be a partner in some of this work. So
Thank you.
Thank
thank
you.
you both. The code for this section is gardenia. I will write that out. Gardenia, gardenia is the code for lecture panda. Gardenia, Gardenia. Gardenia.